Noel, I've got a question.
Okay.
A junior colleague puts in AAA as a differential for a low risk patient who presents with abdominal pain going through to the back. You decide to check previous imaging to find out if you can measure abdominal aorta on those scans and try to exclude AAA in this presentation. How far back can you safely go in order to do this?
So there is no guidelines for this. Let's see if we can get some evidence from out there and make an answer for this question. There is a meta-analysis done, and the study is called Rcem study. What it looked into and what it showed at the end was that for a person to have a AAA growth, relevant of age and gender, it took 2.2 millimeters per year.
Per year. Yeah.
So at the end of 5 years, that's roughly a 1 centimeter.
It should be a 1 centimeter, yeah.
If my math is not wrong. So said that, and if I go back 5 years in a patient and for whatever reason they had an abdominal pelvic scan done and you did not have a AAA in it, and if the patient is low risk clinically, the pretest probability is, then with that normal scan, I can safely exclude a AAA or AAA related complication on this admission and take that off the differential safely. Said that, do you know what are the risk factors a patient can have to develop a AAA?
So COPD is one, hypertension, hyperlipidemia, family history of AAA, okay, smoker, it can be current or previous smoker.
Yep.
I just wanted to ask you one thing. So the way you said about going back 5 years and looking at imaging, what about subaneurysms, the ones that measure 2.5 to 2.9 centimeters, like below 3 centimeters? Mm-hmm. We still call them as subaneurysms.
Yep.
Would you do the same as a negative scan within 5 years?
As per the Rcem study, this explanation holds well for both normal patients and also patient who has subaneurysmal findings underneath, that is less than 3 centimeter AAAs.
So this is valid. I think it's useful because this could be used in practice, to check previous scans and find out. But how confident are we in using this, this way of doing things? Does it hold good for all groups of patients, or should we be worried about particular groups?
Yeah, most definitely. Unfortunately, there are some patients that we can't apply these rules at all. Patient who has a family history of AAA, patient who had underwent any kind of an organ transplant, mycotic AAAs, and a patient who's known to have connective tissue disorder, they have exponentially faster expansion and rupture. So we can't apply this rule on these particular patients. So I think it is safer to say this is something we can use on low risk. Okay, Ranjit, I have a question for you. So let's say you're transferring a patient from district hospital to a tertiary care center for a symptomatic AAA or let's say a ruptured AAA. Surprisingly, NICE guidance doesn't give you a blood pressure control guidance on these particular patients. What is your take on it?
So according to the 2019 Rcem guidance on AAA, they tell us to aim for 90 to 120 millimeter mercury systolic blood pressure, at the same time to avoid hypertension. Whereas if you look at the 2024 ESVS guidelines, they give us a much lower target of 70 to 90 millimeter mercury.
That's quite low.
That is quite low. With this, there are some groups that might be sensitive to lower blood pressure of 70 systolic, and these include elderly people, elderly patients with hypertension, if they've got renal impairment, like pre-existing renal impairment, or coronary artery disease. So for these groups, it would be wise to maintain their blood pressure somewhere close to 90s. The whole point of permissive hypertension is we accept um, systemic hypotension at a balance that we need to keep the patient perfused. So they need to be alert. They need to be producing some urine. At the same time, we don't want to, aggressively give fluids and blood products, thereby disrupting any, stable blood clot that's in there and cause them to just hemorrhage out. So, yeah, that's the whole point of permissive hypertension.
It's surprising how vague nice guidance is in this particular section.
Next question.
Yeah.
A junior colleague comes to you with a patient in their late 60s who collapsed without any typical features to suggest a symptomatic AAA or a ruptured AAA. You, as the senior colleague, decides to do a point of care ultrasound screening for AAA, and you manage to, despite your best efforts, get a view from celiac trunk all the way to SMA. Beyond that, it's just obscured by bowel gas. So you do have a good chunk of the abdominal aorta. Is this enough for you to exclude AAA?
Unfortunately not. Even though we can scan up to 2/3 of the aorta and find nothing, and we can't find the rest of it, cannot be exclude AAA. The reason being is that predominant AAAs are sitting infrarenally. It's about 80 to 90% of AAAs are infrarenal. Suprarenal is less than 5%. So, meaning that even if you get good chunk, like good 2/3 of the aorta scanned, and you can't get to the renal artery and infrarenal, I won't even call this a suboptimal study. I would simply call this an incomplete study. We cannot take this into consideration for anything at all. So unfortunately, the answer would be no. That study is useless.
So that means we'll have to move on to a CT aortogram.
An interesting tidbit. Even if you get to scan the whole aorta and you find a normal-sized aorta in the abdomen, you still can't rule out a ruptured aorta. This is as per the Rcem guidance. So clinical finding governs over the scan. And if you still think it is a ruptured, that patient is going to need a CT aortogram irrelevant of your bedside AAA scan findings. So let's say a patient underwent an elective AAA repair in a tertiary care center. Now they're in RED with symptoms such as abdominal pain, diarrhea, and has a metabolic acidemia in their blood gas. So what are we thinking here?
I would definitely be worried about colonic ischemia here. These patients can present with cramping abdominal pain. It may be localized to the left lower quadrant, or it can be diffuse. There can be frank PR bleeding or hematochezia. There can be diarrhea with blood or mucus. There could be vomiting, nausea, vomiting as well. Also, this pain can worsen with movements and after meals. This can easily be mistaken for infectious gastroenteritis or some sort of hospital-acquired infection. And it's really common. Colonic ischemia is really common after open repair.
Okay, good to know. Since we are in this topic, why don't you also tell me about what are the complications we can look for in this kind of people?
So AAA repair surgeries done both electively and also as an emergency, be it open or endovascular, they are high-risk procedures to begin with, and they carry major complications. The complications are much higher in the ruptured AAA group anyways, because they have high mortality.
Mm-hmm.
Most of the perioperative complications are usually picked up either on table or during the post-op period in hospital. These include things like abdominal compartment syndrome, colonic ischemia, spinal cord ischemia, acute limb ischemia. As an ED physician, it would be relevant that sometimes some of these perioperative complications can come to us as a redirect, or delayed presentation. So it's good to know about it. With that being said, abdominal compartment syndrome usually occurs in the first 24 to 48 hours. So that's not for us. There are long-term complications of AAA repair, and these are different for open and endovascular. For open, you can get things like para-anastomotic aneurysms. You can get obstruction of the graft, infection of the graft. You can also get a secondary aortoenteric fistula, and these people can come as GI bleeding. So you got to be careful if someone comes to you with GI bleeding. on the background of a AAA, or also if they've had repair, you need to be thinking of this complication. So these are really high risk patients. Moving on to endovascular AAA long-term risks, there are the things which I think most of us know about, endo leaks. Okay, so endo leaks occur strictly with EVAR, and then you can also get the graft infection, occlusion, graft migration. So these are things to be worried about.
So it is not far-fetched for us to think as an ED registrar on a shift on a district hospital that even though these procedures getting done in a tertiary care, under a specialist care, these patients can end up in our doorsteps. So these things are good to know and good to watch out for.
Definitely. So like I said, the short-term perioperative complications, fair enough, could be seen mostly in hospital, but the long-term complications can come to us at any time. So someone who comes to us, if you get a patient who comes to us with AAA repair, I think it's good practice to ask about what kind of repair it was, whether it was open or whether it was endovascular, whether it was done electively or as an emergency, whether they had any perioperative complication in hospital. So that kind of tells us what to expect.
So it is always good to start digging into the past medical and surgical history.
Definitely.
And look for these history of a AAA or a AAA repair.
Next question. A patient comes with a known diagnosis of a AAA and tells you that their recent AAA NHS screening found an aneurysm of 4 centimeters.
Mm-hmm.
You perform a bedside screening point of care ultrasound, and you find out that it's 4.7 centimeters now. What's going on here? Is it expanding?
Well, it could be 3 things. It could be expanding, it could be an artifact, or this could simply be the difference in method in measuring. So there are 3 ways you can measure a AAA. We can do the anterior posterior, outer to outer wall, which is what Rcem guidance recommends, is what we do on the bedside.
Yeah.
But NHS screening, interestingly, they do inner to inner. So that alone you can see can give us a difference somewhere between 3 to 6 millimeters.
That's a lot.
Yeah.
Yeah. And I heard there's a third way of measuring as well, lead edge to lead edge.
Yeah, that's something is followed in Sweden.
Yeah, it's sort of in between. So we've got, like you said, 3 things. Yeah, 3 ways of measuring.
3 ways, yeah.
Okay. What about, you said it could be an artifact?
Well, if we remember our anatomy properly, we should remember the aorta goes along the spine and it follows the lumbar lordosis. And if we don't keep our probe perpendicular to the aorta as we follow it down, we end up getting what we call like a salami cuts.
Like a tilted slice.
Exactly. And that can artificially show us a bigger diameter than what it is. It's just purely the cut is not adequate.
Also, interestingly, if we measure the abdominal aorta and diastole, it'll be 2 millimeters lesser.
Again, one more reason to find difference in findings.
I don't know about you, but I have this thing. Whenever if I find a large AAA on scan, on bedside scan, I would wait for the CT aorta, aortogram report to find out what the radiologist measured and sort of pat myself on the back. Most of the time, for a large AAA, I've been wrong, way off.
Exactly. Once that AAA is beyond 5.5 centimeter, CT aortogram and the ultrasound findings, they do not correlate at all.
Yeah.
Here is an interesting tidbit. The same person who's scanning, the same patient at the same moment, and they can still end up getting difference of about 2 to 8 millimeters on that same cut. So there's so many reasons we can have difference in number. It only depends on what the margin is.
Yeah. I mean, that itself could explain why you get, 4 to 4.7 just from the intra-observer repeatability.
Exactly.
Yeah.
That I'm not something going to be sweating over.
Yeah.
All right, here's another question. So let's say you have a patient who you are clinically suspecting a rupture and you do a bedside scan which shows a possibility of that. You do find a big AAA in it and the patient is hypertensive clinically. So you're getting on the phone and you're trying to get hold of the tertiary care center and you're trying to transfer this patient across. But they say, hold your horses, get a scan done, and then give us a call back. What are you going to do?
So according to the 2024 ESVS guidance, we have to do an immediate CT iotogram if you suspect ruptured AAA, and they give it a class 1 level B evidence. Okay, so that it is on us that we need to do the scan right away. Also, the guidance says if the patient with a ruptured AAA comes to us alive, they would be sufficiently stable enough to have that CT iotogram in the first place. Also, the guidance says that even if the patient has hemodynamic instability, if there's a reduced level of consciousness, or if their systolic blood pressure is less than 80, they still can have a CT iotogram. Okay. The only time when you would think about transferring these patients is if they are too unstable, and in an ideal world, these people need to go to OR, where they can have an open repair. Sometimes they can even have an intraoperative angiogram,
Right.
and that can help diagnose the presence of a AAA and also plan for EVAR. This brings up another question. Which patients can be turned down by vascular center for transfer? Someone who you think has got a ruptured AAA.
So Rcem gives a clear set of criteria on patients who can be turned down. The patient who end up having a cardiac arrest on that current admission, secondary to, let's say, because of the rupture, or this patient gets intubated, or needs any kind of a support, like a vasopressor support or an inotropic support. These are patients have been shown that they have very high mortality and is not suitable for transfer or for any kind of immediate surgery. So don't be surprised if these kind of patients are getting turned down right away by the tertiary care center, because there is a good guidance out there saying the poor survivability of these particular patients.
So because they have a negligible chance of surviving repair, or transfer, should we be making this decision unilaterally, or should we still have that discussion with the vascular surgeons?
I would say we should still have the discussion, and these cases can be chosen in case by case criteria.
So what about if a patient lacks capacity, lacks mental capacity? Are they still suitable for assessment and transfer?
Most definitely. That is not a contraindication at all.
And what about if a patient was turned down for elective surgery before, and now they've got a ruptured AAA? So does that mean by default they are not candidates for ruptured AAA repair?
Once again, I would say these patients are worth discussing consultant to consultant, and again, case by case.
So what happens if it's, out of hours, the consultant, the ED consultant is not on the shop floor, they're off-site? Who has the discussion then?
So I'm going to say the overnight epic would be the ED registrar, who can take the decision and can have a chat over. And in spite of that and the other side wants a consultant to talk, then you know who to wake up.
Yeah, that's what Rcem says as well.